So friends, we are here with the new topic, that is the azotemia and the urinary imbalance, right? So let's see what are the objectives of the today's topic. So after the complete of this session, you may know what is the definition of the azotemia and the urinary imbalance, which are the different types of the azotemia. What are the etiology, what are the pathophysiology, what are the different clinical assessment, and which are the different diagnostic evaluation, right? So let's start our first objective, that is the definition. So before we start the definition, remember one thing. So both are the clinical indicators or the underlying renal or the systemic disease. So they are the clinical indicators. Again, they are the symptom, not a disease itself, right? So azotemia indicate the elevated nitrogenous waste into the blood due to the impaired renal functions. So जब renal function impaired होता है, तो जो नाइट्रोजन वेस्ट है, सो वो ब्लड के अंदर बढ़ जाएगा. So that is we called as a azotemia, right? So urinary imbalances, which involves the abnormality into the urine volume and abnormality in the composition of the urine and the frequency of the urine, right? So let's see what are the definition. So let's see first definition of the azotemia. So azotemia means an elevated blood urea nitrogen, BUN, के ब्लड के अंदर यूरिया नाइट्रोजन बढ़ जाएगा, and the serum creatinine due to the impaired renal excretion of the nitrogenous waste, right? So this is, we have be clear, when there is the uh, elevated blood urea nitrogen and elevated the serum creatinine, we can consider the case of the azotemia, right? Another one, it does not always imply the kidney damage. सो ऐसा नहीं है कि किडनी डैमेज हुई है, बट इट ऑल्सो इंडिकेट द डिक्रीज ग्लोमेरुलर फिल्ट्रेशन रेट. सो जीएफआर कम हो गया है, उसकी वजह से जो किडनी की जो फिल्ट्रेशन प्रोसेस है, फिल्ट्रेशन रेट कम हो गया है, इसकी वजह से ब्लड के अंदर यूरिया नाइट्रोजन बढ़ जाएगा, right? So I hope you can easily understand what is the definition of the azotemia, right? Now we move on the another definition of the urinary imbalance. So any deviation from the normal production, excretion, or the composition of the urine, we can consider that is the urinary imbalances. So which are the different terms of the deviation? First, that is the oliguria, means a decrease the composition of the urine. So normal urine output per day, 1500 ml, right, per day. So if it is a less than 400 ml per day, it is considered as a oliguria. So again, you can say urinary imbalances. Anuria, if it is a less than 100 ml per day, we can consider that is the anuria. If it is a more than 3 liter per day, we can consider that is the polyuria. Nocturia, increased urination at night. Dysuria, in the last, we see on the last lecture, painful urination. And the hematuria, blood present into the urine, and the proteinuria, protein present into the urine. So if any one or any two you can found in your patient, you can consider that is the urinary imbalance, right? So I hope you can easily understand what is the definition of the azotemia and what is the definition of the urinary imbalance. So we are moving forward on the our your new objective, that is the types of azotemia. So azotemia we can divide it into the three type: pre-renal azotemia, renal or the intrinsic azotemia, and the post-renal azotemia, right? So let's see first pre-renal. So pre-renal is a due to the decreased renal perfusion. किडनी के पहले का प्रॉब्लम है, किडनी के अंदर जितना भी ब्लड फिल्टर होने के लिए आता है वो कम आएगा ड्यू टू द डिक्रीज रीनल परफ्यूजन. So which are the cause? So first, that is the hypovolemia. So decrease the blood, right? Hypovolemia, or the decrease the plasma, right? Second, CHF, congestive heart failure, right? And third one, that is the shock. So in these three conditions, renal perfusion is a decrease, and it can causes the azotemia or the urinary imbalances. We can consider that is the pre-renal type of the azotemia, right? Second one, itself, the diseases of the kidney itself, intrinsic. So due to the damage to the kidney tissues. So in the case of glomerulonephritis and the acute tubular necrosis, so the function of the kidney will be altered, and due to the alteration of the function, again, uh, सो नॉर्मल यूरिन आउटपुट आना चाहिए वो नहीं आएगा, और जो नाइट्रोजियस वेस्ट जो ब्लड में से प्योरीफाई होके यूरिन में आना चाहिए वो नहीं आएगा, और ब्लड का लेवल बढ़ जाएगा, सीरम ब्लड यूरिया नाइट्रोजन विल बी इंक्रीज, राइट. थर्ड वन, दैट इज द पोस्ट रीनल एजोटेमिया. So it is due to the urinary tract obstruction. So पहले केस में क्या है, किडनी प्रॉपर काम कर रही है पर जो ब्लड आता है वो ब्लड प्रॉपर नहीं आएगा. दूसरे केस में क्या है, किडनी का ही प्रॉब्लम है, ब्लड नॉर्मल आ रहा है पर किडनी फिल्टर नहीं कर पा रही है. और तीसरा केस ऐसा है जो पोस्ट रीनल है, जो किडनी के पास में से जो यूरेटर निकलता है और नीचे ब्लेडर है और यूरेथ्रा है, वहां पे कोई ऑब्स्ट्रक्शन हो गया है, यूरिनरी ट्रैक्ट में कोई ऑब्स्ट्रक्शन है, इसकी वजह से बैक मारेगा, परफ्यूजन होगा, और वो बैक की वजह से प्रॉपर फिल्ट्रेशन नहीं होगा, और उसकी वजह से एजोटेमिया होगा. सो इन द केस ऑफ द स्टोन, tumor, and the benign prostate hypertrophy, in all these three cases, azotemia will be occur, but we can consider that is the type, that is the post renal azotemia, right? So I hope you can easily understand what are the different types of the azotemia, right? And what are the different causes of the azotemia as well as, right? So let's see causes deeply, and what are the etiology of the azotemia. So again, we can consider pre-renal, renal, and the post-renal, right? And you already learned, but let's see once again. Pre-renal causes due to the hypovolemia, in the diarrhea, vomiting, and the hemorrhage, the volume of the blood will be decreased, or the specific gravity of the blood will be decreased. Sometimes the low cardiac output is there, congestive heart failure, which can causes the not proper cardiac output is there. Sometimes renal artery stenosis is there, and the sepsis. So these four you can consider they are the pre-renal cause of the azotemia, right? Now let's see what are the renal causes of the azotemia, right? So first, acute tubular necrosis, renal के ट्यूब्यूल से उसके नेक्रोसिस हो गए. दूसरा है glomerulonephritis or the interstitial nephritis, and the fourth one, they are the nephrotoxin drugs like aminoglycosides, right? So these are the drugs which are damage the kidney. So aminoglycoside, they are the antibiotic, right? The commonest, that is the amikacin, right? So I hope you can easily understand what are the renal causes, what are the pre-renal causes. Now let's see what are the post-renal causes of the azotemia. So once again, like a urethral obstruction due to the stone, due to the tumor, right? Enlarged prostate means benign prostate hypertrophy is there, and the urethral stricture happen. So in these three cases, the urine is not easily pass, राइट. किडनी में से यूरिन फॉर्म होता है पर ब्लेडर तक नहीं आता है, इधर ब्लेडर तक आ गया पर बॉडी के बाहर नहीं निकलता है, which can causes the hydronephrosis of the kidney, and after the advanced hydronephrosis the kidney will be alter the functions, right? Now let's see what are the etiologies of the urinary imbalance. So once again सेम ही रहेगा, but थोड़ा चेंज है. फर्स्ट, फ्लूइड imbalance, डिहाइड्रेशन एंड द फ्लूइड ओवरलोड, दो चीजें हुए हैं, इधर फ्लूइड कम हो गया है, so which can causes the oliguria or the anuria or fluid overload, right? क्या फ्लूइड बढ़ गया है, which can consider a polyuria, right? डिहाइड्रेशन के causes हमने देख लिए, डायरिया, वॉमिटिंग, शॉक, and the fluid overload there will be a edema, राइट, ओवर ड्रिपिंग, बोतल चढ़ा दो साहब मुझे ठीक हो जाए जल्दी, सो आपने दो बोतल चढ़ा दिए, सो फ्लूइड ओवरलोड हो गया, राइट. सेकंड, दे आर द एंडोक्रिनल डिसऑर्डर्स. सो कॉमनेस्ट एंडोक्रिनल डिसऑर्डर्स आर द डायबिटीज, द टू टाइप, डायबिटीज मेलिटस एज वेल एज द डायबिटीज इंसिपिडस, दोनों में तकलीफ रहेगी. Third are the renals itself, renal disorders like a glomerulonephritis, nephrotic syndrome, acute tubular necrosis, right? Fourth one are the obstructive cause, stone, tumor, BPH, etc. And the neurological disorders like a neurogenic bladder, right? And the medications, diuretics and the lithium. Lithium suppress the urine, uh, suppress the urination, right? And the diuretics, when we give diuretics, so the urine will be very fast, right? So these are the different etiology of the urinary imbalance, right? So I hope you can easily understand what are the etiology of the azotemia as well as the what are the different etiology of the urinary imbalance, right? Now we move furthermore into the pathophysiology of the azotemia. सो बेसिकली होता क्या है, कोई भी कॉज रहेगा, प्री हिपेटिक कॉज रहेगा, प्री सॉरी पार्डन मी, प्री रीनल कॉज रहेगा, रीनल कॉज रहेगा या पोस्ट रीनल कॉज रहेगा, कोई भी रीनल कॉज है. सो एट दैट टाइम डिक्रीज द रीनल परफ्यूजन or the damage, which leads to the decreased glomerular filtration rate, which leads to the accumulation of the nitrogenous waste like a urea and the creatinine. Both are increased into the serum, means in the blood, which leads to the azotemia, right? And it leads, now it leads to the metabolic acidosis and the electrolyte imbalances, especially the hyperkalemia, potassium बढ़ जाएगा, and the uremic symptom if we untreated the azotemia, right? So this is the pathophysiology. I hope you can easily understand what is the pathophysiology of the azotemia. Now we move furthermore into the pathophysiology of the urinary imbalance. So oliguria and the anuria, low perfusion हो सकता है या कोई obstruction हो सकता है, which leads to the reduced urine output. Second one, that is the polyuria. Polyuria due to the osmotic diuretics, like in the case of diabetes, और द डिक्रीज एंटी डायूरेटिक हार्मोन एक्टिविटी, जो एडीएच है उसकी एक्टिविटी कम हो गई है, बिकॉज उस वही हार्मोन है जो डायूरेसिस मीन्स यूरिन के फ्लो को और यूरिन की फॉर्मेशन को मेंटेन करता है, सो उसकी एक्टिविटी कम हो जाने की वजह से पोलीयूरिया होता है, राइट. थर्ड वन, दैट इज द डाइसूरिया, हम ऑलरेडी पढ़ चुके हैं, इन्फ्लामेशन और द इन्फेक्शन ऑफ द यूरिनरी ट्रैक्ट विच लीड्स टू द पेन. Fourth one, that is the hematuria, injury or the pathology of the glomerulus or the urine or the urinary tract, right? And the fifth one, that is the proteinuria. So जब glomerular का damage होगा, so वो protein को clear store नहीं कर पाएगा और protein loss होगा glomerular में, which leads to the leakage of the proteins into the urine, which can causes the proteinuria. So these are the pathophysiology of the urinary imbalance. So my friends, you are easily understand what are the pathophysiology of the azotemia as well as the what are the pathophysiology of the urinary imbalance, right? Now हम आगे बढ़ते हैं और देखते हैं हिस्ट्री टेकिंग कैसे करेंगे क्लिनिकल असेसमेंट में. So in the clinical assessment, in the history we have to ask about symptoms like a fatigue. What is the urinary output? So we found the decreased urinary output. So urinary output कम होने की वजह से edema होगा, confusion होगा, nausea and hematuria. We have to ask all these symptoms because हर एक का अलग-अलग cause हो सकता है. After that, we have to ask about the past medical history like hypertension, We have to ask about diabetes into the family and themselves also. We have to ask about infections. Uh, Very most important history taking, that is the medication histories. Then we have to check the Turgor sign for the dehydration, and we have to found the edema for the overload, रिसेंट इनटेक एंड आउटपुट, पानी कितना पिया था, कितना बार यूरिन पास हुआ, वो सब हमें जानना है. देन वी हैव टू चेक अबाउट द यूरिनरी सिम्टम्स लाइक अ फ्रीक्वेंसी कितनी बार है, अर्जेंसी क्या है, पेन है, कोई कलर चेंज हुआ है, बिकॉज रिमेंबर वन थिंग, वेरी डार्क कलर विच सजेस्ट द लो क्वांटिटी और द वेरी उसका कंसिस्टेंसी ज्यादा रहेगा लंबे समय, और जितना भी ट्रांसपेरेंट यूरिन होगा वो ट्रांसपेरेंट लाइक अ वाटर विच इंडिकेट द फ्लूइड ओवरलोड, राइट. So these are the point we have to ask when we take the history, right. Now let's see what can we perform for the examination, right, for the physical examination. Okay. So first we have to check about vital signs, blood pressure and the heart rate. So in the case of hypoperfusion, so BP will be fall down. Uh, we have to take the heart rate also. You found there is a bradycardia or the tachycardia. Signs of the dehydration or the overload, right. We have to found check about the edema, periorbital edema as well as the pedal edema, right. And we have to do the abdominal examination. If you found the palpable bladder, then think about the post renal causes of the azotemia. And if you found the renal angle tenderness, then you think there is a renal cause of the azotemia, right. And we have to examine the neurological for the signs of the uremic encephalopathy के जो यूरिन क्या ब्लड के अंदर ब्लड यूरिया नाइट्रोजन बढ़ जाएगा तो एंसेफेलोपैथी होने का चांसेस भी है. So we have to perform the neurological examination also. So these are the physical examination in the case of the azotemia as well as the urinary imbalance, right. Now let's see what when in which criteria we can consider the diagnostic evaluation, or the which are the different investigation to rule out what may be a cause of the azotemia, pre-renal, renal or the post-renal, right. So first we move with the blood tests. So if this is the azotemia, so serum urea and the serum creatinine both are the elevated, we have to perform the electrolyte test, because to find out the hyperkalemia for the potassium, sodium, chloride and the bicarbonates, right. So वो सब ठीक रहेगा, bicarbonate decrease हो जाएगा. We have to ask check about blood urea nitrogen and the creatinine ratio, right. So in that, if blood urea nitrogen is at 20 gem 1, it is considered as a pre-renal cause, right. And if the blood urea nitrogen is a 10 and the creatinine is a 15.1, uska ratio aega, so we can consider that is the intrinsic cause or the renal cause, right. And nowadays there are the EGFR formula for the estimation of the glomerular filtration rate. So on the basis of the creatinine, we can easily make the formula for the age and that all things. So we can found what are the EGFR. तो GFR estimation करना पड़ेगा. So blood में से इतना पता चलता है. Now we can perform the urine analysis. So we have to ask about a 24 hours urine output measurement. So we can consider that is the oliguria or the anuria or the polyuria, right. Then we have to found the urine specific gravity. So if that is the pre-renal cause, so specific gravity is high, and intrinsic cause means kidney का cause है, so वो specific gravity कम हो जाएगी, right. If that is the proteinuria, hematuria and the cast, so when you found the RBC cast, then think about glomerulonephritis. If there are the WBC cast, think about interstitial nephritis. And if they are the granular cast, think about the acute tubular necrosis. So these are the diagnostic evaluation for the blood as well as the urine. Now we move furthermore into the diagnostic evaluation or the investigation, right? So that is the first imaging में अब हम करवाएंगे ultrasound. So we have to find the size of the kidney. So that is the, if there is the obstruction which can causes the hydronephrosis, right? We can found into the obstruction, or we can found the obstruction also like a stone or the tumor. We can perform the CT scan also for the structural causes of the obstruction, and we have to do the bladder scan. Post void residual कितना बचा है bladder के अंदर वो जानने के लिए bladder का भी USG कर सकते हैं. We have to perform the special tests like renal biopsy for the suspected glomerular or the interstitial disease, and we have to do the fraction excretion of the sodium, which is called as a FENA, fraction excretion of the sodium. So it is less than 1%, so we can consider the cause of the azotemia that it may be a prerenal. And it is a 2%, then we have to think about the causes of the intrinsic cause or the renal cause, right? So friends, I hope you can easily understand what are the diagnostic criteria of the or the diagnostic evaluation or the investigation of the azotemia and the urinary imbalance. So let's see one table for the summarize the all the azotemia and the urinary imbalance. So my friend, blood urea nitrogen and the creatinine ratio more than 20 gem 1, think about the prerenal, is equal to or approximately 10 to 15 gem 1, think about intrinsic cause or the renal cause, and into the post renal cause it will be variable. Urine sodium in the pre-renal it is less than 20, in the renal it is more than 40, post renal में variable रहेगा. Fraction sodium हमने देखा FENA, so pre-renal less than 1%, in the renal more than 2%, and the post renal it is a variable. यूरिन की स्पेसिफिक ग्रेविटी प्रीरिनल कॉज में हाई रहेगी, रीनल कॉज में लो रहेगी, और द पोस्ट रीनल कॉज में वेरिएबल होगा. एंड द रिस्पॉन्ड टू द फ्लूइड, सो प्रीरिनल कॉज में हम फ्लूइड देंगे, बॉटल चढ़ाएंगे तो पेशेंट को अच्छा लगेगा. रीनल कॉज में कोई चेंज नहीं होगा, और द पोस्ट रीनल कॉज में मे इम्प्रूव आफ्टर गिव सम रिलीफ, कि इम्प्रूव होगा और पास होने के बाद थोड़ा रिलीफ रहेगा. सो दैट इज द पोस्ट रीनल, हम उसको मान सकते हैं. सो दिस इज द summary regarding to the azotemia. So friend, now we are move on the management. How can we manage the case of the azotemia? So first we are talk about the general principles of the management in the case of azotemia and the urinary imbalance. So first we have to identify and treat the underlying cause, and restore the maintain fluid, electrolyte and the acid base balance, right? And we have to monitor the renal function parameters like blood urea nitrogen, creatinine and the glomerular filtration rate. We have to prevent the complications such as the uremia, hyperkalemia and the acidosis, and we give the supportive care including the dietary modification and the fluid management, right? So let's see what is the treatment of the pre-renal azotemia. So if we are doing the found there is a pre-renal azotemia, so our goal should be a restore the renal perfusion. So perfusion कम होगा उसको हमें restore करना है. So we can give the IV fluid, we can give the normal saline for the hypovolemia. दूसरे fluid को avoid करना है जैसे Ringer's lactate और the DNS को. And we can give the we have advised to stop the nephrotoxic drugs like NSAID, non-steroidal anti-inflammatory drugs, aminoglycosides, and the ACE inhibitors, right? Another, we have to treat the shock. If we are needed, we can give the vasopressor also like dopamine and dobutamine, right? And if we found the what is the underlying cause, we have to treat the underlying cause. So if there is a heart failure, start the diuretics or the inotropes. If there is a sepsis, then we start with the antibiotics and the fluid. So I hope you can easily understand what are the treatment of the pre-renal azotemia. Now we move furthermore into the treatment of the intrinsic renal azotemia. So first, when we want to treat the intrinsic causes of the azotemia, we set the goal for the minimize the further damage and the support the kidney function, because already the kidney damage will be impaired. So we have not give the further damage. हम आगे बिगाड़ेंगे नहीं, इतना है उसको बचा के रखेंगे और उसको improve करने की कोशिश करेंगे, right? So if the cause is acute tubule necrosis, we have to give the supportive care and avoid the further nephrotoxins like antibiotics, right? And we give the fluid balance, right? If we found there is a cause is a glomerulonephritis, then we have to start the steroids or the some immunosuppressant like a cyclophosphamide, and we have to control the blood pressure, right? If there is the interstitial nephritis, so withdraw the offending drug कि कौन सी ड्रग से हो रहा है वो बंद करना है और the corticosteroid देना है if needed. And if there is an infection, so we have to start appropriate antibiotics who are not a nephrotoxic, right? So this is the treatment of the intrinsic or the renal azotemia, right, my friend? Now we move on the what is the treatment of the post-renal azotemia. So what should be our goal? So remove the obstruction or the relieve the obstruction, right? So first catheterization for the low urinary tract obstruction, like into the case of BPH or the urinary stricture, we can use the Foley's catheter, Malcott's catheter or the simple rubber catheter. यूरोलॉजिकल इंटरवेंशन जो करना पड़े, स्टेंट रखना पड़े तो रख न सकते हैं, नेफ्रोस्टोमी करना पड़े स्टोन के लिए तो कर सकते हैं, ट्यूमर, right? And if any treatment of the relieve the obstruction are not used or the not proper work, then we can do the surgery. In the case of the benign prostate hypertrophy, BPH में प्रोस्टेक्टोमी कर सकते हैं, और the tumor है तो ट्यूमर को remove कर सकते हैं if necessary, right? So I hope you can easily understand what are the treatment of the azotemia, especially the case of pre-renal causes conditions, intrinsic or the renal conditions, and the post-renal condition, right? Now let's see what should we do the steps for the management in the case of urinary imbalance, right? So if you found the oliguria or the anuria, we have to fluid challenge if the pre-renal cause, and we have to monitor the urinary output, right? So कैथेटर करना है और 24 आवर में यूरिन कितना पास होता है उससे हम यूरिन आउटपुट को मॉनिटर कर सकते हैं. Second, if there is a polyuria, what should we manage the cause? So in the case of polyuria, we can manage the cause. Like for the diabetes mellitus, we have to control the sugar. Polyuria will be solved, and same into the diabetes insipidus. And we can give the fluid replacement also, right? If there is a dysuria or due to the UTI, dysuria is there, we can give the antibiotics. If hematuria, so first investigate the cause. What may be a cause of the hematuria? Stone hai, tumor hai, or what is the specific therapy we have to give for the hematuria, right? And if there are the proteinuria, so we have to control the blood pressure, we have to start with the ACE inhibitors, right? And we have to treat the underlying disease why the proteinuria will be occur. So these are the treatment of the urinary imbalances, right? So my friends, you can easily understand what are the different management, specifically allopathic medicine side of the azotemia and the urinary imbalances. So now let's see what are the homeopathic therapeutics of the urinary imbalances and the azotemia, right? So these are the therapeutics drug regarding to the azotemia and the urinary imbalance, but we have to perform the all parameters or the principles of the homeopathy. We have to take the case individualization, and we make the totality of the symptom and find the minimum medicine for the treatment, right? So, but these are the simple therapeutics. First, that is the apis mellifica. So in the in the apis mellifica, the urine will be scanty, burning or the stinging pain. There will be a edema, especially into the nephritis. We can use the apis mellifica. Arsenicum album, restlessness, thirst for the small quantity, albuminuria, and the exhaustion is there. Berberis vulgaris, radiating pain from the kidneys, from like a urinary calculi, bubbling sensation into the bladder and the abdomen. In the Cantharis medicine, there is a burning urination, constant urging, there will be a hematuria and the severe dysuria. Terebinthia, in the terebinthina, that is the hematuria with the fotid smell and the smoky urine with nephritis with the bloated abdomen. A Merck core, so acute nephritis with the bloody and the albuminous urine and the tenesmus of the bladder is there. And the last one, that is the solidago. So that is the kidney and the urinary tract remedy, especially into the case of the chronic nephritis. So friends, these are the homeopathic medicine we can use as a therapeutic. But जैसे मैंने बोला, we have to take the case and we start with the principles of the homeopathy, then we can prescribe the medicine, right? So let's see what are the key point to remember. So remember, azotemia and the urinary imbalances are early indicator of the kidney dysfunction or the systemic disease. Early detection through the clinical assessment and the appropriate investigation are the key to diagnosis and the management. So I hope you can clear regarding your all objective, and uh, you may know what are the definition, what are the etiology, what are the pathophysiology, how can we manage the case, what may be a treatment in allopathy side as well as the homeopathy side of the azotemia and the urinary imbalance, right? So friends, thank you very much. If you found any difficulty or any query, you can contact me and you can ask me. So once again, thank you very much, my friends. Thank you.